Shall I take over now?
Please, Jordan.
Okay.
Thank you.
All right. So thank you for that introduction. Again, my name is Jordan Joseph Wadden, and I am a PhD student and clinical ethics fellow here in Vancouver. And today we're going to be talking about how healthcare decisions are made in a pandemic, and specifically whether these healthcare decisions are still ethical or if they've changed to something more procedural and left the ethics behind. Now, the reason that I'm considering this question, and I hope that you'll find it interesting, is because we've likely all heard complaints or questions in the media or amongst our friends and peers, ranging from things like, why is the government restricting our rights to socialize? Or what does the pandemic mean for my elderly parent? Will they be denied a ventilator? So hopefully by the end of this session, you'll feel like you have a better understanding of how these difficult decisions are made, and how and why they may differ in normal times from how we handle them in pandemic times. So I always like to start these kinds of sessions or lectures with a case, as it can help the more abstract pieces of the presentation or talk resonate better as we go through them. So this is going to be a hypothetical case, but it's one that may sound familiar to something that you yourself have experienced or that you may have seen in the news. So let's imagine that there's this patient named Owen. He's in the hospital receiving palliative care for terminal but not yet end stage condition. For those who may not know, palliative care is often associated with end of life, but it doesn't have to be. It is also used for pain management or symptom management. Now, let's say that he's somewhere in his 20s, making him a legal adult for the sake of decision-making in healthcare, because this is going to make our discussion of the case a little more straightforward. Now, for some reason, pandemic or otherwise, his hospital has decided to restrict visitors for all patients except those who are at the end of life or who can prove the need for visitation for compassionate reasons. We're keeping this open because I want to analyze this case under regular times and under pandemic times to show you the difference. So now we can imagine that this regulation has been implemented between the last time his family visited and now, even if his family visited yesterday, since some policies like these visitation rights tend to move pretty quickly, especially in times of public health crises like pandemics. This policy, say it has been emailed to staff and volunteers late evening last night. Today, his mother and father and his younger sister were stopped at the entrance by to the hospital by a volunteer. This volunteer informed them that the new policy is in place and told them that they're very sorry, but they cannot admit the family to visit Owen. Meanwhile, Owen is inside the hospital, growing restless and distressed because his family should have been here by now. He hasn't been told of the restrictions because the hospital is short-staffed and busy today, so the staff haven't been able to get to every patient yet. Outside the hospital, his family is now worrying that Owen's psychological and emotional condition will deteriorate if they can't visit him. Okay, so that's just going to be our case that we're going to have in the back of our minds, and I will come back to in a moment. When we're trying to talk about changes in healthcare decision-making in this pandemic setting, it helps to understand how healthcare ethics work in regular times. So I'm going to start with this. Generally, there are 4 standard biomedical principles that get applied in clinical ethics cases: autonomy, beneficence, non-maleficence, or non-malfeasance if you're from America, I won't judge, and justice. Autonomy is the ability to make an informed, coherent, and uninfluenced decision. There are many different pieces to making these autonomous decisions, such as the capacity to understand the risks and benefits of a procedure, the ability to understand the process itself, the ability to restate what has been said to you in your own words, showing that you've understood the message that the doctors have given you, etc. Additionally, along with respecting autonomous choices for something, comes the idea that the capable patient also has a right to refuse proposed or recommended treatments of care. Even if this goes against what doctors might want the patient to do, and even if this puts the patient themselves at more harm, they don't really have the right if it puts someone else at harm, but that's a whole different story. We won't complicate the case with that. The next one is beneficence, and this is the principle that says we have a duty to take on actions that benefit the patient and their families. This involves following things like the best interest standard. This is the principle that we need to maximally promote the good of the individual patient in front of us. And this is something that involves both the healthcare team and the patient or their family, or both, determining what the highest net benefit among all available options are for the patient, assigning weights to the interest the patient has in each option, and then subtracting any inherent risks or costs. Following this algorithm of sorts should bring about the option that is in the patient's best interest. The principle of non-maleficence is the piece that says we need to do no harm, quote unquote. It's one of the more common sentiments that you may know from healthcare. In practice, however, not doing any harm at all is nearly impossible, as there will always be some sort of risk to acting or not acting in a case. So this principle, when applied to real cases outside of theory, is generally the idea that we need to choose the option that's going to cause the least net harm. Now, this is different from beneficence, because you could have an option that is super beneficial but causes an incredible amount of pain. Or you could have an option that is almost as beneficial as that one, but causes very little pain. So if we're following the principle of non-maleficence, we're likely to want to choose that second one, even though it doesn't have the highest benefit. In application, this is something that we call following the harm principle, i.e. paying attention whenever there's significant risk of harm. Finally, the last piece in clinical ethics is the justice piece, and it's the requirement that we be as fair as possible when offering care. Sometimes this means acting equitably rather than equally. Equitable action is the idea that there are some groups who are marginalized and therefore need more assistance or resources to receive the same or equal level of care as another less marginalized group. So there's one image that tends to float around the internet every few months that really drives this idea home. And it's the image of 3 children trying to watch a baseball game over a fence. I'll describe it in case this doesn't automatically call to mind this case. There are 3 children trying to look over a fence that is made of wood planks so they can't see through it. There's a tall child who can already see over, a medium child who can't see over, and a small child who can't see over. If we were to be acting equally, we might want to give them all a box because we've equally distributed some boxes. And this would mean that the tall child can still see, the medium child now can see, but the small child may not be able to see yet. So acting equitably in this circumstance might mean giving the tall child no boxes because they can already see over, giving the medium child 1 box because that's all it takes for them to see over, and then giving the small child 2 boxes so that they can see over as well. Now, whenever an ethical issue arises in normal times, such as deciding on visitation for Owen, we need to think of it as a conflict between 2 or more of these principles. So for example, this restricted visitation could be a conflict between beneficence, because there might be some reason in the hospital that just hasn't been conveyed to the family or the patients yet. And that could be at conflict with justice, because there hasn't been adequate time for Owen's family to adjust. Now, when we switch to public health ethics, as we do in major health events and in pandemics, we've moved to a different kind of ethics altogether. Public health ethics doesn't have a set standard of principles. It's not like there's these 4 principles that always get applied in every situation. And this is because they exist in specific contexts. So this doesn't mean that public health ethics only exists in these emergencies. For example, the British Columbia Centre for Disease Control has a publicly available ethics framework for all of their initiatives. And this includes anything from vaccination programs to health education to ongoing overdose prevention. The major difference with public health ethics is that we're now concerned with the health of a community or a population rather than with the health of an individual patient in front of us. So some of the commonly observed principles that focus on a population include things like the following three. Now, again, these aren't going to be in all public health frameworks, but I've picked them because they are in a lot of them. So one of these is the harm principle. This is similar to the non-maleficence harm principle, but instead of focusing on the individual, we're now focused on the right of a population to protect itself from harm, even if this means infringing on individual rights. There's also a principle of least restriction that occurs quite often, which means that any restrictive intervention needs to be the least restrictive option available. We can't go over the top with restrictions. Another principle that comes up pretty commonly is the principle of proportionality. This means that any program needs to recognize, and respond to the fact that there are going to be some individuals who may be put at a higher risk and that they subsequently need to be given more protections or resources. So for example, healthcare workers on the front line are at more risk in a viral pandemic, so they might need to have more access to resources than someone walking out on the streets. One key aspect of public health ethics is that there are two central dilemmas. The first one is it best for a government to limit the privacy, freedom, etc. of its individuals for the greater good? The focus here is that greater good piece. And the second dilemma is, how do we make tough decisions in cases where there aren't enough resources to meet each person's individual needs? All right, so we've talked about ethics in normal times. We've talked about ethics in a pandemic. How does switching to the pandemic ethics change decision-making? Well, when we draw upon public health ethics principles, we're shifting from that individual or autonomy-focused ethical framework to a kind of utilitarian or community-based ethical framework. And using the second approach, the most ethical choice is often the one that produces the greatest good for the largest number of people, rather than necessarily providing the optimal care for each individual who enters a healthcare setting. This means that if an action promotes the safety of a larger number of people than it harms, but still harms some people, it's possible that it would be ethically permissible, even though we're harming those individuals. In a way, this is similar to crude utilitarianism, as I've mentioned previously. There are more specific versions of utilitarianism, so I don't want to totally throw it under the bus, but crude utilitarianism is the kind of ethics that says we need to maximize pleasure, or in this case, benefit, and minimize pain, or in this case, harm, for a population. This kind of framing is useful because it helps allow restrictive measures such as enforcing social distancing, restricting businesses and shoppers, and closing public parks, all of which are useful for a government that needs to flatten the curve, to use a phrase that you likely have heard on the news or in conversations, of an infectious disease such as COVID-19, as we're currently experiencing. This also means, however, that limited resources can be redistributed. In these situations, it may no longer be feasible to give protective equipment to everyone in a hospital. When this happens, priority is given to those who are most at risk. And since medical staff are more at risk than visitors, the easiest way to curb the spread might be to restrict visitor access and prioritize personal protective equipment for staff. Now, what doesn't change is that we still try to provide the best care possible based on our clinical ethics standards. Clinical ethics principles like autonomy and justice don't just get thrown away in a pandemic, even though it might seem that way based on how media or doctors themselves might talk just out everyday lives at the moment. So rather, we try to find a balance between continuing to provide the best care that we can, while also understanding that the best has now changed and may be less than optimal care. So let's return to Owen to examine his conditions under both normal and pandemic settings. So under normal circumstances, this enforced restriction might not be ethically justifiable, at least not in the way that it was presented in that case. And that's because we're supposed to be operating on those individual-based ethics: autonomy, beneficence, non-maleficence, and justice. Restricting the visitation in normal circumstances is infringing on both Owen's and his family's autonomy, and the volunteer hasn't been able to give reasons why overriding this autonomy is required. This restriction is also not in Owen's best interest, nor does it seem, and it seems it could actively harm him, as he's confused and distressed, and his family thinks that this could deteriorate his condition. This also just doesn't seem fair. It's a non-emergency setting. Patients and families should have been informed of policy changes with ample time to adjust. However, let's switch to the pandemic version of this situation. Let's say that Owen is someone in the hospital right now with COVID-19 going around. If there's an immediate threat and protective equipment needs to be used to prevent spread, we're going to have to go through much more than we typically use, especially if we're going to be allowing visitors, because they're going to need to be given protective equipment as well. If this hospital has a limited stock, then the safest change for everyone, the staff, patients, and the visitors, and their communities, might be to restrict visitation. This also respects proportionality, since staff are at a higher risk than visitors, and it's the least restrictive option, as allowing visitors without protective equipment could spread the virus more than not allowing them in at all. What needs to be maintained, and what isn't captured in the brief summary that I gave for Owen's case at the beginning, is that his care still needs to follow clinical ethics as best as possible. Perhaps, since his family can't visit, the staff might be able to find a tablet that would normally be used for education purposes, and that can be repurposed to have some sort of video chat between Owen and his family. So now that we've gone through the ethics themselves and a case, the next question is likely, how are these decisions made in these contexts? How do we decide what principles to put onto these frameworks? So during non-pandemic times, there are often many other ways to achieve public health without resorting to these restrictive or infringing methods. And that might cause some tension, since in normal times we can promote public health without restrictions, but in pandemic times we say that we need the restrictions. So the reason that this is different in normal times is because we're not held to the same limitations with resources, and we have much more time to work out problems in most cases. Now, we still have time constraints and we still have resource constraints, but they're not to the same degree. This pandemic is going to end, even if it doesn't feel that way. And shifting to public health ethics will then change back to our regular clinical ethics. This isn't meant to be a long-term or permanent change. However, for the time being, we need to follow the public health population principles. And this leads us to our question that I led this slide off with on how are these set? How do we decide what principles are best suited for a given major health event? So importantly, these frameworks aren't made on the fly. They aren't created by a single meeting, nor are the principles cobbled together on a whim by people who are asked by the media, hey, what's the framework? Instead, these frameworks are built on evidence-based research on the specific health event itself. For example, an Ebola framework would be built using our knowledge about Ebola in other countries or from past outbreaks. For novel events such as COVID-19, where there's a lot of uncertainty about what this virus is and how the condition continues and progresses, we tend to draw on research as it comes out and on the literature that most closely relates to the condition. So we might draw on influenza pandemic literature if we want to try to figure out what might be good to do for COVID. We also make sure to draw on previous frameworks. So this means that the COVID-19 framework would have been built, and I can confirm was built, with some recognition of previous BC frameworks. For example, the Ebola and the swine flu frameworks may have had some key considerations that transfer over to this pandemic and thus would have been used. They would have been modified, but they would have been used as some sort of grounding to start the framework off. And finally, these decisions on the creation of the frameworks are made with many professionals in the field, and they get vetted by several levels of organizations and politics within the health authorities as well as the government. So in short, they are not developed on the fly, not even close, which should bring some confidence, even if we don't necessarily understand why all of the pieces are there. Now, these frameworks are also developed with the thought that they can be used as a guide in various ways for both healthcare professionals and for the common everyday person who might not be trained in healthcare. So first, it's going to be a process guide. It demonstrates a simplified decision-making process so readers can understand how we make a decision in a pandemic. The framework also serves as a values guide. It demonstrates what are the primary values for making population-level decisions. We'll get to those on the next slide. These are importantly unranked. And it's possible that a given decision that we make will require us to make trade-offs between the values. So it's possible that we might not be able to capture all of the relevant values, but we try to pick the option that is the highest, or it does the most of the values. And finally, the framework serves as a guide for identifying the particular values within a specific case within that larger health event. So we can think of this as combining the first two roles together. It ensures that we have a well-defined process and that we follow and articulate our grounded values. So the British Columbia Ethics Framework for COVID-19, that's the one that I have the most knowledge of, and that's the one that I'm going to talk about here, because that is where I am based and that's where UBC is based. So it seems to make the most sense for this kind of audience. This was released a few weeks ago, and it is publicly available. You can Google BC CDC COVID-19 Ethics Framework, and it'll take you to a webpage that has the PDF. And there were 9 principles that were chosen for this framework in particular. So the first principle or value is that of respect. When making a decision in a pandemic, we need to ensure that individual autonomy, liberties, and cultural safety are respected as much as possible. The second one is the harm principle. And this is different, again, from the regular clinical ethics harm principle. And this one is saying that society as an abstract entity has the right to protect itself from real or threatened harms, even if this means infringing on individual rights. Third, we have a principle for fairness. This is different from equality because it states that those who can get the most benefit from limited resources should be prioritized, that resources should be distributed to maximize benefits to the population, and that allocation of resources needs to be made with consistency. This consistency piece means that within a hospital, all like cases down the line need to follow the same as the first decision unless new information has come out. But this also means that we're trying to be consistent, at least within health authorities, if not across the whole province. Fourth, we have the principle to be at least restrictive and coercive as possible when making decisions that infringe on individuals' rights and freedoms. So that's something like enforced social distancing. So I can give an example of what we mean by this least infringing. You can imagine, as is true for COVID-19, that there is a virus that spreads through social contact. So we can have 3 possible, for this very simple example, 3 possible measures to implement. We can not implement anything at all and hope that people will self-isolate themselves. We can enforce social distancing by closing shops, by limiting hours to different stores, by having fines, or we can heavily fine and enforce, in which we fine anyone who is found outside. So you can't do any exercise, you can't walk your dog unless you have a permit or something. This is something that happened in, I think it was France. They had to go to a website and kind of register what they were out of the house for in case a police officer stopped them in the streets. They could look them up and make sure that they had filled out this form. So that seems pretty restrictive because you're not even able to go out to exercise without having to ask permission. And we would say that that isn't the least restrictive possible to mitigate at least what we're seeing over here in Canada, at least what we're seeing here in BC. But then not doing anything at all and hoping that people will isolate themselves doesn't seem to work, as we saw earlier in March that people were still going to public parks. So the least restrictive that still gets us some action is that enforced social distancing with the threat of fine if it is found that you were in negligence of some sort. So that just kind of explains that one a little bit. So fifth, we have the principle of working together, which means cooperation at all levels: individuals, health regions, provinces, and nations. Now, this includes individuals in healthcare, but it also includes individuals in the general population, following regulations and helping each other out. So maybe there are individuals who can't go out to the grocery store. Working together is a neighbor helping that individual as well. That follows and is actually promoted by these kinds of frameworks. Sixth, we come to the principle of reciprocity, which states that those who are asked to take increased risk or who are put at increased risk by healthcare decisions ought to be protected and have their risks minimized as much as possible. We then have the principle of proportionality, which means that any decisions must be proportionate to the risk or threat that they are designed to address. This is kind of like the least restrictive, but instead of on restrictive measures, it's on those positive measures that you're trying to promote. So it's like the two sides of the coin with this one. There's also the principle of flexibility, and this is because we're in an evolving health event. We have no previous data to go on for COVID-19. It's not like Ebola, where we might have previous studies. So we need to be flexible to shift and change our approaches as we learn more information about the virus. And finally, there's the principle of procedural justice. This one handles the accountability we have towards one another whenever decisions are made. It's the principle that says we're required to be open and transparent. We're accountable to our decisions, and that our decisions have to be reasonable, rational, evidence-based, and practical. This principle has the least to do with the everyday person and is primarily for those making healthcare decisions at a policy level. Now, these public health frameworks aren't without their criticisms. In particular, if a framework relies too much on crude utilitarianism and emphasizes too strongly the greatest good piece, several communities and subpopulations can be left more vulnerable. This criticism is particularly raised in the current pandemic with the framework that's used in Italy. There were recommendations made that made it seem as though elders wouldn't be treated at all in an attempt to save those with the most valuable years remaining. Other groups that could be affected by this include, in a large way, the disability communities, especially those who already require more resources, already are using assisted breathing technologies. I've seen several of these reports myself about people who are already on ventilators for their everyday, scared that they are now disposable. And this is why, for the BC framework at least, we're trying to recognize and include the fact that clinical ethics isn't replaced by public health ethics. Rather, there are principles that are maintained as best as we can. This is captured by the flexibility, by the proportionality, by several of the public principles that were chosen. Another criticism of public health principles in general is that they could be seen as if they treat individuals as merely vectors for transmission. This draws on criticism from deontology, which is another of the main philosophical ethical theories that is a partner to utilitarianism. And this criticism says that by focusing on the abstract entity that is the population, we're failing to respect the dignity of individuals. In the BC framework, this is addressed by the inclusion of principles dealing with respect, reciprocity, flexibility, etc. Again, we've tried our best to handle that. And then the harder criticism is that acting on public health principles and the policy decisions that come from them has implications for areas of society that aren't healthcare. For example, there are people whose jobs can't become work from home jobs, which can result and has resulted in the loss of jobs. There are also people who will continue to work and put themselves at higher risk than everyone else, but they're unable to use protective equipment on the job, or at least unable to use much protective equipment. And this is going to be people who work in delivery or who work at grocery stores, etc. And this is This is the much harder question to answer. But with that said, I'm now finished the lecture part of this session, and I'm going to turn it over for questions and discussion from all of you. Thank you.
Thank you, Jordan. So before we go to questions, I just want to remind our listeners today how exactly to ask the questions. And I see during your lecture, Jordan, we were receiving some questions that I'll go into very soon. But in the meantime, for our listeners who arrived later, we have turned off the chat feature in Zoom, and instead we're inviting people to open a new tab in your browser and type in slido.com. You will see an event code, and today's event code is UBC1H. So I'm just going to go into my present mode, and people will see questions. I'll highlight them. I'll be moving back and forth as people send in questions. So the first question, Jordan, is, I'm wondering about the ethics of non-COVID related healthcare essentially being on hold right now. People having necessary surgeries and treatments being delayed, etc. Right.
So that is something that I know at least we're talking about at the health authority that I'm currently a clinical fellow for. The main issue that's happening there is that, at least for non-essential surgeries, which that might sound like a strange title, non-essential surgery. If you're requiring surgery, it seems like it's essential, but non-essential surgery means anything that isn't emergency or urgent. At the moment, because we're trying to act on these public health principles, that means that we can't necessarily give the most recognition or the best care. It means that we can still give good care, but not the best care. And that might mean delaying surgeries and treatments and upping, say, pain medications or symptom management, or trying to help relocate a patient to a different center for the time being. These patients aren't just being forgotten about because their surgeries and treatments are delayed. It's just we're trying to also balance, one, not infecting them for having them in a hospital in the first place, but also trying to minimize the use of personal protective equipment, minimize the number of people that are going to be in a location that has active COVID cases, because even if someone comes in for surgery, doesn't get, they don't have COVID, they might leave with COVID because it was just in the hospital. So I'm not sure if that's a totally satisfying answer, but basically everything is kind of going on a case-by-case method, depending on the institute and depending on what the surgeries or treatments themselves are and what our resources are.
Thank you. Another question here that I've just highlighted, Jordan. How do we promote public trust in evidence-based frameworks when decisions are politicized? For example, when governments are taking action on the conflicting information around masks.
Yeah, and this is one that's really difficult. So a lot of the time, the frameworks are being built by ethicists working in the hospital and teams that are close to those ethicists. And then they're getting sent off to politics, where politics is, of course, messy. And that's really frustrating for us because we're trying to get the most information out there and make it evidence-based, and then it sometimes gets twisted. So how we promote public trust the best way possible is having sort of education sessions like this, or having open discussions outside of hospital settings, or just trying to communicate what that evidence is as best as possible. That's really how we're trying to take this on and still promote these frameworks that are evidence-based. That also means not necessarily reacting to misinformation, but for sure calling it out. Because if you react to the misinformation, you might feed the trolls, as it's sometimes called online, and then that'll just inspire them to write more information because they're getting attention. But we do still try to call it out. Yeah.
Okay. Thank you. Next question. Could you comment on the ethics of the decisions you talked about this a little bit in your lecture. Could you comment on the ethics, Jordan, of decisions which might have to be made with determining who gets ventilators?
Yeah. So right now in BC, we're still trying to set this framework. It is something that most provinces, at least provinces in Canada, are trying to have some sort of framework specifically for this decision. The ethics of that one gets really, really, really difficult, because up until the point where you need to start withdrawing or withholding, you can try to be cautious and give it only to those who need it the most and try to do other methods. But the fear is always that you're going to get to the point where we can't do that anymore, someone needs to come off. So the best I can answer, because I don't know what BC's response to this is, I don't know what Canada's response to this is, because these frameworks aren't released publicly yet. But the best that I can answer is that there will be some sort of framework. I know that because I know of one in the works. And then teams will be specially assigned to working through that framework whenever those questions come up. And it will be frameworks similar to this generalist COVID framework. It'll have principles laid out, it'll have justifications for these principles. But it's a tough decision, and I don't envy those who have to enact or create the framework.
Mm-hmm. Mm-hmm.
I really don't envy them.
Thank you, Jordan. Yeah. Yes, it certainly is difficult. The question I'm highlighting now goes back to one of your slides. For Owen's case, what could be the best possible way to deal? What could be the best possible way to deal? If a family member decides to lock down with Owen, is it within the current ethical framework? So,
right. So the best way to deal, I was trying to kind of hint towards that at the very end with maybe repurposing an education tablet as now a video conferencing tablet to still have some sort of connection. Because it might be the case that Owen just needs to have some sort of communication and that his family doesn't necessarily have to be there. That's something where we would want to look at that individual case. And this goes back to the fact that the clinical ethics don't get thrown out. So we would go back to that individual, we would go back to their case, and we would try to figure out, okay, what are the specific needs of this patient, of Owen here, and how can we best approach those? Maybe we can't do everything possible because we don't have the resources anymore. So we can't admit his family. For some reason, we just can't give them compassionate reason, because he's not end of life, he's just palliative. But if we change that case a little bit and say that his family are involved in his feeding and that he only eats when his family is there, that might be grounds for getting compassionate visitation in so that they can come in and feed him so that he doesn't deteriorate. So really, the best possible way to deal really depends on much more detail for any one particular patient than that vignette really gave. But I'm really glad that this question came up.
Okay, thank you. Next question, Jordan. What does the new policies enforced mean to those who require periodical treatments such as dialysis and chemotherapy?
Right. So this kind of goes back a little bit to the question over those who are having their treatments delayed or having surgeries delayed. This is a little more intense because it's something that isn't necessarily able to be delayed. And this is, again, going to depend. This is probably not a very satisfying answer either, but it's really going to depend on the case itself. So if it's possible to move the patient to another hospital that can do their chemotherapy or their dialysis that has less COVID patients, say to keep it in the current pandemic, then that would be one option. We would move them for the time being. We might try to get people who can, if it's some other type of procedure, we might try to get nurses or medical staff who can do home visits. We would always try to go through as many of the options as possible and try to consider how best to treat this patient, despite the fact that they might normally go into a hospital that is now entirely a COVID hospital. I know here in BC, we have COVID units, but we don't have COVID hospitals, at least to my most recent knowledge. But we might try to move them to a different place that has less likelihood of them being infected, or that has better access to resources for whatever reason. Maybe they hid some stockpile before all of this started happening, and they just have more now. Who knows? But we would still try to get those periodical treatments in as best as possible, recognizing that that might mean shaking things up a bit for the patient.
Mm-hmm. Mm-hmm. Okay, thank you. Yes, because of course all those treatments still need to proceed.
Absolutely.
I have no idea if you can answer this. Sugar's gone. Oh no, there it is. When do you think the pandemic will end? Is that an unfair question, Jordan?
It's
sort of a personal opinion question.
Do we want my optimistic or do we want my realistic?
Oh, optimistic, please.
Optimistic is soon being like a month or two, but realistic is we just honestly don't know. When it comes to pandemics, it's all about how well we're able to flatten that curve, how well we're able to contain outbreaks, how well we're able to contain the further spread. And this is a particularly difficult pandemic because, one, we don't know COVID-19. This is a novel coronavirus. And two, unlike, say, SARS, where you were generally only infectious after you started showing symptoms, for this one, you're infectious before you show symptoms, and that can last up to 14 days. So it's really hard to do those containment practices when it's so difficult to identify who might be infected and who might be asymptomatic. So the realist answer is, I don't know. No one really knows.
Right.
We can make good guesses, but no one really knows. Mm-hmm. And if anyone claims to know, they are just trying to make you feel better.
Right. And don't you think also what would be taken into consideration, given that here in BC, we're maintaining, below the curve, mm-hmm. we're doing pretty good, mm-hmm. but who's going to feel comfortable getting on a plane in 6 months or a year's time to travel to Europe? So there's going to be still a lot at play.
Or even on a bus to go in between provinces.
Right.
Especially with central Canada versus eastern Canada right now, with Ontario and Quebec, just increasing, no matter what they're trying. That could have happened to any of us. Right. BC's been doing good, could have happened here.
Yeah. Certainly something came into play here a little bit better in that they caught a lot of families before they headed off for spring break, unlike Quebec and Ontario. Yeah. That was a great question. Thank you.
It was a great question. I'm happy that that one came up. Yeah. Even though That's the one that I have the least possibility of answering.
So, does the desire for equitability in care assume that we can achieve the impossible goal of equal outcomes? What are the consequences of equal allocation of care?
Right. So the desire for equitability, it doesn't necessarily assume that we can achieve equal outcomes. What it does is it tries to approximate those equal outcomes. So we might not be able to get two patients to the exact same baseline, even if they started at the same baseline. But we might be able to get them roughly back to that baseline. And that's all that equitability is trying to get at. It's not trying, in theory, yes, we want to get them to the same line. But in practice, we know that that's not possible. And we know that our patients know that that's not possible. So we just try to approximate as best as we can to what we would consider that equitable equal zone. So to answer the second part of that, what are the consequences of unequal allocation of care? That really depends on how we are being unequal. If we're being unequal because one patient is in better clinical health, and they're younger and they're XYZ, and another patient is in just worse health for whatever reason, they've been hit harder, they have comorbidities, something like that. If we're being unequal by giving this person more of our resources, then that's actually ethically justified because the other person actually needs less to get up to their baseline again, whereas the person who has those comorbidities needs more. But if we're being unequal because, say, Jim Pattison is a COVID patient, and then just random person from the downtown east side is the other COVID patient, and we give more to Jim Pattison, even though the downtown east side might be the person who is showing the most comorbidities, that's where unequal treatment starts to become a problem, because we're allowing our prejudices, we're allowing our biases, we're allowing finances and politics into our clinical decision making.
Right, thank you. So Jenny is asking, what's a good indicator of when it's appropriate to start up work again, I guess, by getting back to our normal lives? If we open before a vaccine is discovered, how different will work operations be?
Right. So this is kind of like the second to last question, where I don't know what a good indicator would be. So I'm trained in ethics. I'm not trained in epidemiology. So if I was to try to answer this question, that might be a little irresponsible of me. I can give a bit of an answer towards the second part. If we open before a vaccine discovers, what is that going to look like? And that depends on where we're at regarding containment when we decide to reopen. If we're at a point where it's been mostly contained, meaning that there's no new cases arising, it's been twice the length of a regular infection period since a new case has been announced, then that would be just like the SARS pandemic or the MERS pandemic that we had earlier in the century. Because the SARS pandemic didn't end because we found a vaccine. We still don't have a vaccine for that, but there are no new cases in the world because we were able to contain it. So it might be the case that we open before a vaccine is discovered for exactly that reason. We have it contained. If we open before a vaccine is discovered and it's not contained, then work operations are probably going to be very similar to what work operations are now. Whoever can stay home stays home, try to limit social connections, etc. That's the best I can offer on that one.
Right, and I appreciate your honesty, Jordan, in attempting to answer it. Thank you so much.
Of course.
And likewise, for any other question, if you feel that I can't answer that, please don't hesitate to push back, Jordan. So here's another question. how does the pandemic affect the ethicalities of people with a Chinese background? They face a colossal amount of racism.
Absolutely, they do. Absolutely, they do. And we see this with things like President Trump saying that this is the Wuhan virus, well after everyone said that that was an inappropriate thing to call it. And that's another thing that we need to start getting more public engagement and public education out on, is that effect of racism that comes into any major health event that happens. Because a lot of the time, whenever there's some sort of outbreak or some sort of pandemic or some sort of new virus, it gets attached to a group, and then that never truly leaves that group, and it really, really harms their everyday lives. But it can also harm their health, because people don't want to treat them, people don't want to engage with them. They start suffering mental health because people are adding even more racism to their lives. So basically, the best way to combat this is for everyone, not just health individuals, to be calling this out whenever the racism happens. So if you're on a bus in, say, 6 months, when we feel comfortable going on buses again, and someone starts yelling at someone who looks vaguely Asian because they've sneezed or coughed, stepping it, if you're not comfortable like telling the person to stop, stepping in between them and that other person so that they basically have to talk through you as a wall, can do a world of wonder for that, for stopping that racism.
Thank you. Great advice, Jordan. Thank you. Dominique is asking, and I'm just watching time now, we're at 1:57.
Oh,
So
wow.
Dominique, yeah. Dominique is asking, do you think we'll start seeing more implementation of increased testing and tracking here, since so many people are not being tested?
That's one of those questions that I would have to be an epidemiologist to answer, unfortunately. It's
Okay.
not an area of the hospital that I get to involve myself with.
Okay.
Sorry.
Okay, no problem. What do you I've highlighted one, same from Dominique. What about undiagnosed patients who need referrals and are already on long wait lists, who don't have access to meds or anything yet?
Right. So undiagnosed, I'm assuming in this case, is undiagnosed with some other condition than COVID, because of the referrals and the long wait lists and whatnot.
Right.
Unfortunately, for the most part, that would fall under the same realm as those who are having delays. So those long wait lists might be frozen for the moment, depending again on what the condition is. If it's something with a dermatologist, that might be completely frozen for now. Whereas if it's something for cancer of some sort, or some organ system not functioning properly, that's probably not frozen. It might be slowed down, but it's probably not frozen. Unfortunately, that means access to meds is also problematized. And that's something that we try our best after these frameworks are out to address and fix as they come up. Yeah.
Okay. I'll do maybe a couple of more questions. How about what do you think about people who don't stay home?
Oh, I just want to yell at them from my window. Like I understand the sentiment. They're not seeing it themselves. They don't want their liberties restricted. I get that. But it's also not just about the individual. It's about the population. So you could become asymptomatic. You could have a very light case. But then if you're interacting with, say, your parent, or you take a cab and then someone else who's older or who has a pre-existing condition, like myself, because I have a lung condition, takes that same cab immediately after you, you've now put them at risk because you didn't stay home. So that's what I think about them. I think
Okay.
they need to stay home.
Thank you. I'm just quickly viewing questions here. Will policies to boost wages of care aides so that they will not need to A, work in more than one facility, and B, come to work sick, be permanent? I guess should it be permanent? Is another
Yeah,
question.
so I can answer that in two different ways. Will it be permanent? I don't know. If I had to guess, probably not. Um,
Mhm.
but again, we're gonna we're gonna be entering a totally different world after this. So anything that comes up during this time, like those assistance programs, might stay. I truly don't know. Should it be permanent? I think people should have better wages, and I think um, working in working in one facility instead of more than one facility would be helpful because you are now able to spend your time really learning that facility and really engaging with those patients instead of trying to flip all over the place. So should it be? Maybe. Maybe. I can see the argument for that.
Mhm. Okay, thank you. It is 2:02. I'd love you to ask this, see if you take an answer at this question. Um, have the social distancing and individual liberties restrictions been analysed through a gendered lens?
Mm.
Women are taking on childcare and homeschool.
Yeah. I know that there have been some more popular media analyses of these, like people in the New York Times or whatnot, talking about this, and also talking about like the increase in domestic violence that may be happening
Right,
now that we're just not hearing about.
right.
Um, I don't know if that's being even brought to people who are making these frameworks to consider, um, or how it would be considered though. So I know that these are being analyzed. I'm just not sure who or how far they're being analyzed.
Okay, okay. Question here. What kind of policies might be in place for long-term travel-related restrictions post-pandemic?
Right. So that's one that is more of a an after the fact thing to decide on after we've seen what has worked, what hasn't worked. Once this is all done, said and done, I can imagine there'll be something around travel while sick. But beyond that imagination, that's something that we really need to wait to see what worked before we can try to discuss this.
And Dominic is asking, sorry, I'm just going to move back between. There was a, yes, so honestly, I'm going to cut off the questions pretty soon, but I just wanted to ask a couple that are interesting. Do the ethics of allocating increased resources for treatment change when the person is a politician, for example, most recently Boris Johnson? I
Yeah.
had to throw that in.
Yep. No, I get that. They shouldn't, is the short answer.
Mm-hmm.
If we're talking about public health ethics and we are truly interested in it being public health ethics, then no, it shouldn't when someone is famous or when someone already themselves has more resources or when someone's a politician. Um, do they in practice? I think that's an inevitable kind of secret yes, um, where it's not like, oh, everyone in a health authority is told, hey, if this person comes in, they need to be treated, but the team on the ground that day might treat them differently, kind of thing. That goes along with a lot of our implicit biases, because we can be implicitly biased against someone, but we could also be implicitly biased towards someone. So that's one of those like perennial problems rather than just a COVID problem.
Okay, and this is the last question.
Okay.
Dominique is wondering if the healthcare system is prepared for an influx of mental health issues, as many will likely come out with anxiety disorders.
Yeah. I mean, people who work in mental health are already calling for more resources before this pandemic. So is it prepared? Probably not. I can't definitively answer that because I'm not in mental health, but probably not, given that mental health professionals are already saying that they need more resources and that they're already very overworked. So I can imagine that that is going to have some sort of policy change after the fact, where we can say, look, this is now happening. In a way, this is becoming its own pandemic as a response to the pandemic, and then it needs to change. I can absolutely imagine that happening, and I hope that that would happen, because again, they're already saying that they're overworked and whatnot.
Is it a good time to be a psychology student?
Maybe.
Thank you, Jordan. So I'm going to, before I say goodbye to yourself and to everybody, I just want to give our viewers some updates. Um, in that the update I got this morning from my colleague is that our lectures are all full. Our upcoming 5 lectures over the next number of weeks are full. But please remember that we are recording most of the lectures when permitted. And they will be ready for viewing a number of days, a few days after the actual lecture. They'll be on our UBC Extended Learning YouTube channel. So please let your family and friends know, again, if they've missed registration, we will be putting them on our website. And if anybody needs to contact us, our email is info.exl@ubc.ca. I'll repeat that, info.exl@ubc.ca. And so thank you, Jordan. Thank you for being our first speaker.
Yeah, of course.
Really,
I'm very happy to have been able to share what information I do have about these kinds of things.
yeah, I really appreciate it and really enjoyed it, and I could relate to it with regard to the different restrictions, because I too have family all over the world, so it's interesting, and friends, interesting sharing what's happening at different times
Yeah.
and different parts of the world. So that was interesting. So yeah, thanks for coming forward with such an interesting question to consider and debate. And you could tell from our questions that our audience enjoyed it as well.
Oh, absolutely.
So
I'm really happy that a lot of those questions were very hard.
I know, I'm glad you were
I'm
answering them
very
and not
happy
me. Well,
about
thank you for tackling them, even the ones that you felt that you were not experiencing. I do appreciate you tackling them as well.
that.
And of course, thank you to all our participants for joining us today and making us part of your Tuesday. Really do appreciate that. And I'll say goodbye for now. Take care, stay safe, and hope to see you soon over the next few weeks at our upcoming lectures. Thank you. Goodbye.
Bye, everyone.